Thanks, Tom, and thanks for putting this together. Thanks for the opportunity. What I'm going to do is tell you two things. One is that we need to know more about this process. We need to know more about how we can identify people who are at increased risk. That's the first thing I'm going to tell you. The second thing I'm going to tell you is what we know. And we don't know a lot, but we do know some things. So this is what I'd like to try to cover. We'll talk about the current colorectal cancer screening guidelines, making the point that family history is an important determinant of risk, and hereditary colorectal cancer contributes disproportionately to young onset colorectal cancer. And then I'll talk about who else, besides those with a family history, should start screening at an earlier age, and what we can and should do now. And that will leave you understanding why we need to know more about this. This is just a list of risk factors. You've seen this list several times today already. But my point is that only these two are used to stratify screening recommendations in the United States, or really anywhere. Although the Australian guidelines do talk about obesity a bit, most guidelines around the world do not. But age and family history. So I'm going to talk about family history first. This is just the age distribution, the cumulative incidence of colorectal cancer in a population with no family history versus a family history. The point here is that the age of onset of colon cancer is younger in people with a family history. That's why screening recommendations are different starting ages in these two populations. In addition, the risk of colorectal cancer increases as a function of the age of the cancer in the relative and the number of relatives with colon cancer. The lifetime risk of colorectal cancer in the United States in both men and women is about 5%. If you have a single first-degree relative overall, a single first-degree relative, it increases that risk 2 to 3-fold. If you have more than a single first-degree relative or a first-degree relative under the age of 50, it increases that risk 3 to 4-fold. If you have more than 2 first-degree relatives with colon cancer, it increases the risk almost to the level of Lynch syndrome risk. So number and age of relatives with colon cancer is a very strong risk factor for this disease. Having an adenoma, a first-degree relative with an advanced adenoma, that is one that's larger than a centimeter or has villous histology or has high-grade dysplasia, is essentially the same as having a relative with cancer. This is a little-known fact to the general population. This is something that we can really do something to improve education about the importance of advanced adenomas. Screening intensity increases as you move from left to right along this continuum. So this is the recommendations, the current recommendations based upon family history. Average risk individuals, the recommendation is to start at age 50 with any one of a panel of screening options. If you have a first-degree relative over the age of 60, just one first-degree relative over the age of 60, the recommendations vary a little bit. To either start at age 40 or 50, to use either colonoscopy as the preferred option or any of the screening tests. So a little bit of variability here, but an option for starting early in anyone that has a first-degree relative with colon cancer. And in fact, in one of the guidelines, anyone with a first-degree relative and adenoma of any sort. And that's at least half the population. And so that's a big group if you actually follow those guidelines. There's very consistent guidelines in these other groups. If you have a first-degree relative with a young onset colon cancer or have more than a single first-degree relative, the recommendations are uniform to use colonoscopy as the preferred option and to start at age 40 or 5 to 10 years younger than the earliest cancer in the family. So family history makes a big difference with respect to screening. And there's a large segment of the population, at least 10 to 15% of the population, that falls into these categories and should start screening earlier. Many of them don't know that, and we certainly do a very good job of screening. So it's important for the patient, the individual, to know their cancer family history. It's also important for them to know their adenoma family history. So we need to do a better job of knowing our family history. We need to do a better job of acting on it. This is some data. So relatively recent data looking at the frequency and the time trend of colonoscopy within the previous 10 years in populations that have a first-degree relative greater than age 50 and those that don't have a first-degree relative greater than age 50. And you can see those with a family history have slightly higher rates of colonoscopy screening, and it's improved between 2005 and 2010. However, if you look at individuals that have a first-degree relative and should start screening at age 40 rather than 50, and look at the screening rates in the 40 to 49-year-old, the rates are substantially lower. So we're not doing nearly as good a job in following screening guidelines in these individuals with a family history. So we clearly have work to do. We can improve this. So it's important not only for individuals to know their family history, but it's important for their providers to not only know their family history, but actually act on that family history. But I want to go back to the average risk population for just a second, because this is not a homogeneous group. But what it means is that you have no personal history of an adenoma, you have or any colonic neoplasia, and no inflammatory bowel disease. Screening recommendations are different if you have had a previous adenoma, regardless of whether it was identified by screening or symptoms or whatever. So it's very important to recognize that these individuals, that there's screening recommendations that are different. And I'll come back to that point in inflammatory bowel disease as well. However, even within those that meet this average risk condition, there's substantial variation of risk on the basis of sex and on the basis of race within the population. And I'll just show you that. This is the age distribution of colorectal cancer in the overall population, and then men in blue and women in red. And you can see that at any age, the risk is higher in men than it is in women. The age distribution is about the same the differences are about the same magnitude as having a first-degree relative with colorectal cancer. It's shifted about 5 years to the left in men compared to women. We don't make any recommendation for different screening recommendations on the basis of gender. Similar is true for race. This is data that show in the middle, these two lines are the colorectal cancer incidence rate in white men and black women, these two in the middle. Up at the top in red is the incidence in black men. Down in the bottom is the incidence in white women. Substantial differences as a function of race and gender and colon cancer risk, and differences that are just as big as those based on family history. We make a difference on the basis of family history and screening recommendation, but not on gender and race typically. But all of the major organizations that have looked at screening recommendations, most of them have considered whether to make special recommendations on the basis of these factors. The U.S. Preventive Services Task Force considered recommendations based on gender and based on race, and decided after looking at the data not to tailor them, largely because we're not doing a good enough job in using the recommendations that we have now with respect to screening, and they were worried about making them more complicated. And I think that's a legitimate worry. But no tailoring was recommended. The American College of Gastroenterology and the ASGE do use this information. They recommend considering starting at age 45 in African Americans. From what we've heard today from Dr. O'Keefe and Dr. Corlitz, maybe we should also include other populations like Alaska Natives, like Acadians. There may be other populations that we should also consider starting early, and I think individual physicians do that in their own setting. But there's not a general recommendation for that. And in fact, there's only a couple organizations that recommend starting earlier in African Americans. But it is important to recognize that there are guidelines that would be consistent with starting earlier in some of these populations. Well, how about hereditary colorectal cancer? This is the sort of distribution of colorectal cancer overall, largely dominated by individuals over age 50. 70% are sporadic, about 25% or so have a familial component. About 5 to 7% of colon cancers are due to some hereditary predisposition, well-defined hereditary predisposition. If you look at individuals under the age of 50 with colon cancer, this fraction down here just about doubles. As you get younger, it gets higher yet. And this is one study that's a little bit biased on the basis of the ascertainment of this patients, but this is a group of individuals with colon cancer very young age, unusually young age, less than 35. And you can see that these hereditary groups, shown here labeled with the red titles, is about almost a third of the entire population has one form of the hereditary syndrome or another. So as the population gets younger with colon cancers, the relative contribution of hereditary syndrome increases. And so we really need to be aware of this as a component, not the major component, but an important component of young onset colorectal cancer. I think we need to look for these syndromes. There are now 15 hereditary colorectal cancer syndromes. It's no longer just Lynch and FAP. We've got MUT-YH. We've got the Pol E and Pol D. We've got GRIM1. We've got 5 polyposis syndromes. We've got 7 or 8 other colon cancer syndromes, including hereditary breast ovarian cancer that's associated with increased risk of colon cancer as well. We're learning a great deal about this. There may well be other genes in this population that we haven't looked for adequately enough. So I think hereditary syndromes are important. Clearly, screening recommendations vary greatly in these hereditary syndromes, starting very early, using colonoscopy very frequently in these populations. So here's a population that we need to identify better. We know that less than 10% of Lynch syndrome families have been identified in the United States. We just do not do a good job here. We need to really improve our ability to recognize these families, and that will make an impact on young onset colorectal cancer. So how do you recognize these patients? These are the factors that we use to try to identify hereditary cancer syndromes. We need to know about a hereditary cancer syndrome that's already been defined in families. There are relatives of folks from families that don't know that their relative has hereditary syndrome. We need to test individuals' cancers for microsatellite instability and try to cull out the Lynch syndrome group from that. Early onset cancers, cancers that occur at a very young age, colon, breast, or endometrial cancer, for example, less than age 50. This is one major way. Multiple cancers in a single organ, like bilateral breast cancer, multiple cancers in a single individual, and multiple cancers in the family. These are the hallmarks of hereditary syndromes. And then there's some unusual cancers, like male breast cancer, for example, is a hallmark of hereditary cancer. Small bowel cancers are a risk. And then people with numerous polyps. The threshold for genetic testing is more than 20 adenomas in a lifetime. And some, if you have a positive family history, more than 10 adenomas in a lifetime. So there's a substantial number of folks that we should be looking for these hereditary syndromes. There are other groups that should have screening starting earlier. The most important is this group, symptoms. Average risk individuals don't have symptoms. That screening is for asymptomatic average risk individuals. Symptoms and identification of symptoms early and workup of symptoms is perhaps the most single important thing we can do. So symptoms are important. The second most important thing is symptoms. The third most important thing is symptoms. Do not ignore the symptoms. All right? And then you can talk about these other things. You can talk about people that have a history of colonic neoplasia adenomas or sessile serrated adenomas found no matter how they're found. People that have an adenoma or more, the recommendation for them is to have their next surveillance exam between 3 and 5 years, regardless of whether that's before or after age 50. So there's this group as well that needs to be identified. Inflammatory bowel disease is not uncommon. In fact, it's quite common to occur before the age of 50, and so people that have inflammatory bowel disease for 8 years or longer, the recommendations are for them to start screening at that time, regardless of age. People with abdominal radiation in childhood are also at increased risk, so that's an important group that needs to be identified. And remember, all we're talking about here is payment. Anybody can get screened for colon cancer. Anybody can go out and buy a FIT test. Buy a colonoscopy. It's whether your insurance company will pay for it or not that we're really talking about. So it's really important to remember that these rules and guidelines don't mean that you can't get screened. You can get screened. Your insurance company may not pay for it, but you can get screened. It's really important to remember that, I think. So what can you do now? What can we do right now? Don't ignore symptoms. Discuss colon cancer screening with your provider. But the providers need to discuss it. Patients need to discuss it before age 50. If you wait till age 50, to do the discussion, you've missed the opportunity to identify individuals that should be screened earlier. This is really an important educational point for both providers and patients, is that we have to ask the question at the right time as well. I think what's important to follow family history-based guidelines. There's good evidence that we don't do that well enough. There are certain populations where it's perfectly appropriate in their guidelines that will support starting screening before age 50, and we talked about those. And the last point I'd like to make is that it's really important that we understand more about this. We need to understand early onset colorectal cancer better. We need to know what the real contribution of hereditary syndromes is using a broad brush to identify the hereditary syndromes, not just looking for Lynch or FAP. We need to know what the molecular profiles of young onset colorectal cancers are really, so that we can then look at risk factors as a function of the molecular profile that's dominant in young onset colon cancers as opposed to older. And that tends to be, there's a preponderance really of microsatellite stable, chromosomal stable colon cancers in young onset individuals. We need to know what the risk factors are for that molecular subtype of colon cancer, whether it occurs in young people or older people, to find out whether that might be driving, those risk factors might be driving this issue in young onset people. There's a lot to do. You can be part of that. If you are a survivor, if you've had colon cancer at a young age, I'd really encourage you to get involved in research, to have systematic hereditary testing, and to have your tumor submitted for molecular testing. Thank you very much.